Very good morning to all of you. Welcome to the World Asthma Day Academic Program 2024, organized by the Sri Lanka College of Pulmonologists, collaboration with the Indian Chest Society. Today, we gather here for a day filled with insightful discussions and knowledge sharing. To inaugurate the event, please rise for the national anthem. Kindly remain standing. To start us off on auspicious note, we will now have the lamp lighting ceremony. We have esteemed gathering among us. May I please request following dignitaries to join us in the lamp lighting ceremony. Guest of honor, Dr. Champika Vikram Singha, Deputy Director General, Non-Communicable Diseases, and President, Sri Lanka College of Pulmonologists, Academic Chair, Professor Dushanta Madigadara, and representing chairpersons and senior consultant pulmonologists, Dr. Amita Fernando and Dr. Kirti Gunasekara. Secretary of the Sri Lanka College of Pulmonologists, Dr. Sachini Senivaratna, and Secretary of the Sri Lanka College of Pulmonologists, Dr. Upul Patirana. Representing the speakers and current treasurer, Dr. Damit Rodrigo. Business Manager, Emergent Life Sciences, Mr. Janaka Kumarage, and representing Medical Officers, Dr. Erandi Kolonne. Representing a student, please kindly invite one monitor of the group. Senior Consultant Pulmonologist, I kindly inviting Dr. Vijit Senaratna to join the lab lighting ceremonies. Thank you. To welcome you all officially, I have great pleasure in inviting the President of Sri Lanka College of Pulmonologists, Dr. Niranjan Dissanayake, for the inaugural speech.
Thank you, Mithuni. Good morning, ladies and gentlemen. It is indeed a pleasure to represent the Sri Lanka College of Pulmonologists, the main stakeholder of controlling and treating patients with respiratory diseases in Sri Lanka, with their organization of the World Asthma Day in 2024. I'm indeed honored by the presence of you today, and especially in a context where asthma is a significant disease in Sri Lankan context. So when we look at the global variation, I think one of the main characters of this ISAC study is in front of us, Dr. Kirti Gunasekara. And we have found that Sri Lanka, with this red star, is one of the main countries in the world where, especially when we are dealing with children of 13 to 14 years who had V's in the past 1 year. And when we have severe asthma in the same age group, we have about 7.5, more than 7.5 prevalence have been found in Sri Lanka. Again, a red star for us. When you look at the 6 to 7-year-old children, again, we have a red star. More than 20% children having wheezing within the last 1 year. And then severe symptoms, again, in about 7.5 to 8% of patients that have been found. So especially in this age group, the ISAC study has found that Sri Lanka, even in 2009, had been a high burden country of wheeze and asthma-related symptoms. In 2017, again, this was further confirmed by this study, Sri Lanka being identified as one of the highest burden countries, having more than 10% of the population having asthma. Now, recent studies, as I think Sir has been a part of this study, this is done in Kandy, and we have found that in children, we have about 12% of the children having symptoms that has suggestive of asthma. And these have been compared with Kandy and Anuradhapura, and we can see that there is a slight statistically significant difference between the districts of Sri Lanka, probably suggesting some changes in the environment or the genetic structure of these patients. And when we look at the past 12 months symptoms, one of the major features is that only about 58% of these children have been properly diagnosed as asthma by a doctor. So there is a bit of underdiagnosis in these patients. And at the same time, when you look at the symptom burden, around 70 to 80% of these patients are still symptomatic in this age group. When we look at the 13 to 14-year-old, again, the current wheeze and symptoms of asthma is about 15% higher than the younger age group. And fortunately, most of them have been diagnosed as confirmed by a doctor, 82%. But again, when we look at the symptom burden, they are probably under controlled in majority of the instances. So these studies tell us one thing: asthma is prevalent in these age groups, as well as, unfortunately, even though some of these patients are diagnosed by the doctors, the control is not that adequate in these children. So when we look at adults, I think Sir is one of the main authors here, Dr. Kirti Gunasekara. So we have basically found this is more than 35-year-old population, where wheezing, tightness of chest, and symptoms suggestive of asthma had been there around 23% of the population. And again, in these patients, even in patients who are on current medication, right, the symptoms in persons on current medication for asthma, unfortunately, wheezing is present in 82%, symptoms of chest tightness 52%, and about at least more than half, sometimes 8 out of 10 people, even on treatment, are not properly symptomatically managed in this patient. So there is a significant gap in asthma control in the adults as well as in childhood as well. So what about the pregnant patients in Sri Lanka with asthma? We know that asthma has significant comorbidity to the mother and the child, has significant negative effect to the mother and the child. So this study done recently has showed that the self-reported doctor-diagnosed asthma was about 6.6. This was actually a telephone conversation, and only 41% of the pregnant mothers who are already diagnosed of asthma are on proper treatment. So we know that under-controlled asthma in pregnancy, we know that 1/3 of them will go into exacerbations, and some of them will have poor outcomes. And this is the current state of pregnant patients with asthma. And 33%, 1 out of 3, had at least unfortunately had a hospital admission due to exacerbation of wheeze. And this would have been devastating for the child as well as the mother. And unfortunately, in this cohort, birth weight is about 16%. So we have significant gaps in asthma management or asthma diagnosis, asthma management in children, adults, and pregnant patients. That means we have to do a lot more. Unfortunately, when you look at the deaths, some of these deaths might be attributed to non-asthma causes, but unfortunately, we have about 6,400 deaths in 2020. That is the reported value by the WHO, and we are the 10th country according to the rates with asthma deaths. So there is much more to do, and these deaths happen. This is a 14-year-old coming to the ETU on admission death. To a hospital that I worked previously. So these are true values, and these are true happenings that are happening in the country. So one of the possible main reasons of this is the neglecting of what we so-called mild asthma. So what we call mild asthma is less than weekly symptoms, only 1 or 2 probably per week or less than that, symptoms happening in a patient with asthma. And when we look at it, 40% of our asthma population, or half of this population, belongs to this, what we call within bracket, mild asthma. But in this age group, in this group, mild asthma group, if the asthma is not properly controlled, 1 out of 3 or 2 of them might go into acute asthma within the next 3 months, and 1 out of 5 patients will have a near fatal asthma experience, and 1 out of 5 has a probability of dying of asthma. So even though we say mild asthma, this is a significant cohort of people. 50% of our population, if not properly treated, might go into exacerbations, because the number of huge, rather than the severe asthma, we only have about 3 to 4% of patients, but about the 96% of the people, 40% is a huge amount, and some of these people might die if we don't treat asthma properly. One probable reason is that the overuse of what we call the blue inhaler, because now even in the GINA guidelines before 2016, they were treating mild asthma with as required blue inhaler, which has now shown to be harmful. And at the same time, because of the recurrent use of this blue inhaler, unfortunately patients are now taking the blue inhaler because they get an immediate relief, rather than they are not thinking about the control, they are thinking about the immediate relief. And unfortunately, they don't understand the gravity of taking the controller medication in asthma. And that is one reason that probably asthma, comorbidities and uncontrolled asthma is high in Sri Lanka. This picture is one of our patients who came to the clinic. Most of them have 3 or 4 blue inhalers, but some of them don't have the brown inhaler at all. So I think you all also will be experiencing this problem. So now, since 2019, we don't recommend SABA-only treatment, but unfortunately in the Sri Lankan context, still there is a lot of use of slow-acting bronchodilators for the asthma patients for symptom management, which is against the guidelines that we know of in mild asthma. So what they suggest now is the GINA guidelines in 2023, and it has changed from 2019. We have to, even in a patient with a so-called mild asthma, we have to give a steroid to this patient together with a bronchodilator for symptom relief. So that is the current standard of care for these patients. We can give the steroid as a regular basis. We can give beclomethasone or any steroid together with a short-acting bronchodilator, but not the short-acting bronchodilator alone. So that is one of the major changes that has happened in the GINA guidelines, and it will change patients' outcomes markedly. Now, one thing that patients want is symptom relief. So even if they take the brown inhaler, they will not get the symptom relief, but we actually have formoterol, which has a rapid action, which is similar to salbutamol. So when they have formoterol together with a steroid, they will have a rapid action similar to the salbutamol, but they will together they will have a steroid inside as well. So then they will have an improvement of outcomes. Now when we compare the low dose ICS formoterol as required with short-acting bronchodilator alone, there is a 55 reduction of severe exacerbations. And when we compare with the daily ICS plus short-acting bronchodilator, again there is a reduction of severe exacerbations in these patients. And when we look at the steps 1 and 2, you can see that compared with maintenance dose ICS and SABA, we have a significant reduction of exacerbation. At least it is similar in patients, and patients are preferring to this treatment rather than taking 2 inhalers together, and we know how the patients behave. Right? When the important thing is whether the cost, right? So this is the lowest dose inhaler meters dose salmeterol budesonide that we have, 1625, and this is the beclomethasone that we have. So we are thinking about maintenance dose beclomethasone, and at least if a patient, in the mild group, now we say the symptoms happens at least less than 1 or 2 times per week, but if even the patient takes 6 times a week, so the formoterol budesonide, the daily average spending amount is about 10.83 per day. And when we look at the beclomethasone, permanently we had to use beclomethasone, and we had to issue a salbutamol inhaler as well. So if we think that the salbutamol inhaler lasts for 6 months, even the expense is more than this one. And when you look at the step 3 and 4 maintenance, again when we compare with salmeterol, fluticasone and formoterol budesonide, again we see that it favors the use of formoterol budesonide. At least it has a similar effect than formoterol budesonide. And when we look at if you look at the prices, you have to take formoterol budesonide daily in this patient. So usually the MDI has 120 doses per 60 doses, 60 days. So 27.8 per day. And then if you have this salbutamol inhaler, which is prescribed with the salmeterol fluticasone, 3.4 for 6 months, then it comes about 29.2. So when we look at the economics as well as the patient outcomes, I think now it's a time that we have to shift towards guideline-based treatment when managing our patients with asthma, which is cheaper when we think about the drug, and at the same time when we think about the amounts of exacerbations that are preventing, the amount of deaths that we are preventing, amounts of hospital admissions, and the associated care that we are preventing, we are saving a lot of money in this process. When you're looking at severe asthma, which has about 3% of the asthma, we really need to improve our treatment paradigm, because we really don't have these drugs at our armamentum at that time. We don't have omalizumab freely available in Sri Lanka. That is for the severe asthmatic group. We don't even have dupilumab or any of these drugs in Sri Lanka at the moment for the control of severe asthma patients. So it is time that we think about this and try to improve our outcome. So basically, when we look at asthma in Sri Lanka, I think there is much need to improve our services with asthma for the general population. For the majority of the patient who doesn't have severe asthma, simple management, about 40% to 50%, can be managed with appropriate guideline-based simple management, which can be given to the patient. If available at the primary care and the secondary care level, most of these patients can be managed. So we are a high burden country, there is no argument about that, and we see a lot of morbidity and mortality, loss of life, loss of daily functions in these patients with asthma. And then we have uncontrollable symptoms in patients who already have diagnosis of asthma. Probably they are not using the correct inhaler, not using the correct technique, and there is much more to do, and probably they are not using the correct treatment as well. And we have guideline-based cheap drugs in the market, and the important thing is, when we treat this group, we have a group of people who have severe asthma. We should have state-of-the-art treatment facilities for these patients in Sri Lanka, even though they comprise probably about 2 to 3% of the patients' population. So we need a center of excellence for asthma, hopefully, and with MDT, multidisciplinary team-guided treatments where biologics will be available in Sri Lanka, so that we will be able to treat this patient population. So we, today with the World Asthma Day today, so hopefully if we can get together, the policymakers, the college, as well as our doctors, and for the people, if we can get together, probably within about next 2 or 3 years, we might have a better picture of asthma in Sri Lanka. Thank you very much. And it is indeed a pleasure to have all of you here, especially our Deputy Director General of the Non-Communicable Disease, Dr. Champika Wickramasinghe, who came without any hesitation for this inauguration. My dear teachers and mentors, Professor Madagedara, who is the academic chair, Dr. Keitha Gunasekara, Dr. Vijay Senath, and Dr. Amita Fernando, and my senior teachers, Director of the National Program for Tuberculosis and Control and Chest Disease, as well as the consultants there, and many more who has come here today to this inauguration of the World Asthma Day. And I hope that you will have a wonderful academic session today. Thank you very much.
Thank you for that great introduction, sir. Now we are moving to next session. The World Asthma Day 2024 is a collaborative event with Indian Chest Society. Here is the message from Dr. Raja Dar, Secretary of the Indian Chest Society.
Hello friends, my name is Dr. Raja Dar, and I am the National Secretary for the Indian Chest Society. It's a historical day for all of us today. It's for two reasons. First, this is the first collaboration between the Sri Lankan College of Pulmonologists and the Indian Chest Society. Second, the occasion for which we are collaborating is World Asthma Day. The theme for World Asthma Day this year is Asthma Education Empowers. And that is what we plan to do for all of you today. Educate you, update you, and hopefully improve your knowledge so that your patients can be managed better with asthma. To do this, we have got a wonderful panel who will talk to you about various aspects of asthma. I am here only for logistic reasons and to pay my regards to the entire team of the Sri Lankan Society for Pulmonologists. My aim today is to make sure that this is the first of many collaborations between these two societies. The topic could not have been any better. The topic is something which is a huge problem in the entire subcontinent, which includes India and Sri Lanka. In India, as per the Global Burden of Disease report, we had about 35 million asthmatics in India. This amounts to about 2% of the Indian population. That is, in reality, less than the percentage of asthmatics in other countries of the world. So does that mean asthma is a lesser problem in India? Indeed, it's not. It's a massive problem. Look at the DALYs lost. Look at mortality. India stands above any other country in the world. Let's take mortality first. 45% of the global deaths from asthma hail from India. So think about it, 45 out of 100 people dying from asthma come from our country. This highlights a few important points. The fact that asthma, though recognized, needs to be managed better. Second, the myths and taboos around asthma, including the use of inhaler therapy, the use of inhaled corticosteroids in the management of asthma, the importance of compliance and technique, the importance of control of triggers, looking out for comorbidities, and making sure that we treat these comorbidities in a relevant fashion, and to find out various overlaps, be that overlap with COPD, be it overlap with bronchiectasis, overlap with sleep apnea, the comorbidities like gastroesophageal reflux disease. All of these need to be addressed properly if asthma control needs to become better. That is what we strive to do today. Hopefully, this collaboration will also, in the future, translate into research collaboration, where we find out more data in areas of asthma, but also other chronic lung diseases. Hopefully, this will open a new chapter for both societies where we work with each other, pick up best practices from each other, and hopefully promote a respiratory medicine across these two countries and also across the subcontinent. My heartfelt thanks again to our partners in Sri Lanka, my colleagues and friends in Sri Lanka. I hope the program goes very well today. I'm sure it will do with all the efforts from teams on both sides. I look forward to listening to the academics that gets shared on this platform today. Stay well, happy World Asthma Day, and better breathing for all of us across two countries. Thank you very much, and I look forward to hearing you all on this meeting.
Thank you, sir. It's my great pleasure in inviting Dr. Champika Vikramasinghe, Deputy Director General at the Directorate of Non-Communicable Diseases, Ministry of Health.
Good morning. Dr. Niranjan Disanayaka, President at the College of Pulmonologists, all the past presidents and the council and members of the College of Pulmonologists, Director in PTCD, all the consultants and medical officers present here. It gives me a great pleasure to address you today on the day of the World Asthma Day. In line with the theme for this year, educating on asthma, I think our president has arranged this, and I thank him and appreciate him for his enthusiasm. And what has struck me is, when we come to meetings, consultants talk of new medicine and new protocols, but I have never seen anyone talking about the cost of drugs. But today I have seen that, and I greatly appreciate his consciousness and also his justification, and it has opened my mind also to all the work we have to do from the Ministry of Health side in improving the asthma treatment and also improving the life of people with asthma. When we look at our morbidity pattern, most of the outpatients actually go to primary care because we have around 1,000 primary care and around 60 secondary and tertiary care. So I would like to request President of the college to join with us and help us in organizing a very good program to treat our medical officers at the periphery at primary care on asthma treatment and management. Because as I have seen, a lot of new knowledge has come, and the treatment has changed and the principles have changed. So it is high time we train our medical officers on these things, and also I think our formulary and those things also need some amendments, and I will give you my fullest support to improve the asthma care. When we consider NCDs, we have done a lot of on CVD and hypertension and also on cancer, and I think it is time we concentrate on chronic respiratory diseases and work on it. So we'll start. We have already prepared the guidelines and all, but we'll work together and improve on the guidelines and also make available technology at primary care level, and also introducing new more effective and also cost-effective drugs at primary care and also at OPD level, improving our clinic setup. All those things we can concentrate, and I hope a president will give me fuller support in organizing these things. So we'll work together for the improvement of asthma care for patients. Thank you very much.
Madam, please remain on the stage. I now kindly invite the President of Sri Lanka College of Pulmonologists, Dr. Niranjan Dissanayake, to deliver the token of appreciation to value your presence.